Hello, everyone. Welcome to the webinar learning series for Nutritional Therapy for IBD. I'm Dr. Gauree Konijeti from Scripps Clinic in San Diego, and joining me to discuss the role of the Mediterranean diet for inflammatory bowel disease is Dr. Lihi Godny. Dr. Godny is a registered dietitian in nutrition working in the Division of Gastroenterology at the Rabin Medical Center in Israel, where she is actively utilizing and researching the Mediterranean diet for IBD. She'll be sharing some of her research with us in this area. She also serves as the chair of the dietitians for the European Crohn's and Colitis Organization. This program is made possible with the support from Abbott Nutrition. And Dr. Godny, it's great to have you with us.
Thank you so much, Dr. Konijeti, and thank you for the invitation to speak here today. I'm going to speak about the Mediterranean diet and to try to answer, does the Mediterranean diet have a role in patients with inflammatory bowel disease? So we all aware that IBD, the incidence and prevalence of IBD is rising all over the world, but epidemiology shows us that currently the sharp rise in the incidence and prevalence is mainly in the Western countries and countries that currently developing or adopting a Western lifestyle, like India, like China, and that really highlights the environmental components of the pathophysiology of IBD. And we know that both diet and the microbiome are key players in the pathophysiology of IBD. We know that patients with IBD have an altered microbial composition, reduced microbial diversity, reduction in beneficial microbial groups, and increase in microbial groups that are considered to be more pathogens or more pro-inflammatory, like E. coli, like Fusobacterium, etc. And the microbiome and the diet interact with each other. We think that more Western dietary pattern is associated with a more pro-inflammatory composition, and more healthy dietary components like fruit and vegetables are actually associated with more healthy microbial composition. And Western diet is actually a high-fat, high-sugar diet, but currently and recently, we don't really focus only on the composition of the diet, but on food processing. And we know from epidemiological studies that ultra-processed food intake is actually associated with increased risk for the development of inflammatory bowel disease. So Western diet is more associated with IBD. And if you look biologically, so a group of researchers from Harvard speculated that if Western diet, high in red meat, processed food, refined sugar, saturated fat, can promote dysbiosis and impaired barrier function, the opposite diet, which is the Mediterranean diet, rich in fruits, vegetables, whole grains, is actually associated with microbial diversity, with intact permeability, and can promote immune tolerance. And if we'll zoom in to the intestine, we can see in this study that illustrates the component of the Western diet, that refined carbohydrates, a high ratio of omega-6 to omega-3, and low quality fats, red and processed meat, salt and additives. This kind of dietary pattern and components can actually impair the barrier function, cause leaky gut, impair the microbiome composition and function, and promote inflammation, as opposed to Mediterranean diet with its polyphenols, at the low omega-6 to omega-3 ratio, a high quality fat, mainly olive oil and monounsaturated fatty acids, micronutrients, and dietary fibers can actually promote intestinal barrier integrity, a more diverse and rich microbial composition, and with that promote more immune tolerance as opposed to a Western dietary pattern. So this is the Mediterranean diet, but what is actually the Mediterranean diet? So if we're focusing, we're zooming in into the Mediterranean Sea. So you can see it surrounds by many countries with different cultural habits, with different religious, different dietary habits. We can see Spain, France, Italy, Greece, Turkey, Syria, Israel. I'm here, by the way. We can see Egypt, Libya, Tunis, Algeria, Morocco. So these are very, very diverse. And this is a very nice website, Taste Atlas, that shows you actually the food of the different countries. And again, so we know that we have the olive oil in Spain and many other countries. We have the pizza and pasta in Italy. We have in Israel, we have hummus and falafel. We have the couscous in Morocco. So we have many types of dishes, many cuisines, and very diversity in the different dishes, cuisines, and eating habits. And a very nice study from Australia interviewed immigrants from the Mediterranean Sea and Mediterranean countries to Australia. And they actually divided the Mediterranean region into 4 different regions. We have the Western that contain Spain, France, Italy, and Malta. We have the Adriatic region, Croatia, Bosnia, and Albania. We have the Eastern, including Greece, Lebanon, Cyprus, Turkey, and Egypt. And we have the North African countries. And they actually divided the different food components. So you can see clearly here that we have some common denominator, but different regions eat differently. You see, for instance, for olive oil, so we have countries that consume olive oil, but we have other countries that don't consume. The fruits are vary, and also the vegetables are vary. You know, we have the sofrito over here, we have more salads in the eastern parts, so it's not really the same. But the first person that actually defined what a Mediterranean diet is was actually an American. This is Professor Ansel Keys, which is very known for his studies that link between fat content in our diet and cardiovascular and coronary heart disease. And he actually linked between the fat consumption and fat composition. It's not only fat consumption, but also fat composition, mainly saturated fat, and increased risk for cardiovascular disease. And he was actually traveling to South Italy and Greece, and he described the diet, the traditional diet that was known in the Mediterranean diet. He and his wife wrote a book, Eat Well and Stay Well. This was the first book, and afterwards, Eat Well and Stay Well with the Mediterranean Way. And later on, it was adopted by Harvard, the researchers from Harvard and Always Foundation, and they actually described the Mediterranean pyramid. So on the basis of the pyramid, we see food components that are recommended to be consumed on a daily basis. We can see fruits, vegetables, whole grains, legumes, nuts. Olive oil is the main source of oil. In a moderate consumption, we have the animal products with preference of fish over chicken, and we see some amount of cheese and yogurt. And on the top, which is food that we recommend to reduce, is red meat, sweets, and processed foods. And red wine is recommended on moderate consumption. But on the basis of the pyramid, you can see that it's not only a diet, it's actually a lifestyle. It should be an active lifestyle, and the Mediterranean diet promotes that we should eat with family and friends, and to choose local and seasonal food components. So this was the definition of the Mediterranean diet. And many times I've been asked, okay, so the Mediterranean diet, can it be globalized to other countries or other regions as well? So I just wanted to highlight that Actually, in 2022, this was the fifth consecutive year that the Mediterranean diet won as the number one diet by the US News. Best overall, best diet for healthy eating, best heart healthy diet. So it's not, only for the Mediterranean region. It actually can be applied globally, and it is known for many health benefits like cardiovascular disease, mortality, cancer, diabetes, neurodegenerative disease, immune-mediated disease like psoriasis, rheumatoid arthritis, and so on. And in IBD in the recent years, when I started my PhD in 2014, I think there weren't many data regarding Mediterranean diet and IBD, and I'm very happy to see that in the recent years, we see the accumulating data that actually support the recommendation of Mediterranean diet in specific subsets of patients with IBD. It is associated with multiple beneficial outcomes, and it is actually researched not only in the Mediterranean region, but actually globally in North Europe, North America, and so on. I just wanted to highlight few studies that demonstrate the beneficial effect of the Mediterranean diet. The first study is the D-ECCO conducted by Jim Lewis and his colleagues in the United States. In this study, patients with active Crohn's disease, they actually recruited nearly 200 patients with active Crohn's disease, and they were randomized into the specific carbohydrate diet or the Mediterranean diet for 6 weeks. In the first 6 weeks, they actually, the researchers provided food to the participants, provided the meals, and after 6 weeks, they recommended to continue follow the recommendation according to each diet principles. And here you can see the week 6 outcomes. You can see comparable symptomatic remission rates and fecal calprotectin response. So it was comparable and around 40% of symptomatic remission. If we will compare it to other dietary strategies like the Crohn's disease exclusion diet, so it's a bit lower in the Crohn's disease exclusion diet. In the adult study, we see 57% of symptomatic remission on week 6. But again, this is not this is a significant portion of the patient that responded to the diet. And in the fecal calprotectin response, we see only 30% of the participants that achieved at least 50% reduction in fecal calprotectin. And again, it was comparable to the SCD, but only in the SCD we see significant reduction from baseline. But I think that one of the limitations of this study, and here you can see the CRP response, which was relatively rare, but one of the limitations of this study is that it included patients with relatively lower levels of inflammatory markers, so it was underpowered to see this effect. But again, this is one option, induction of remission in active Crohn's disease. Research needs to focus on other strategies that may increase the symptomatic remission rates, for instance, maybe combination with partial enteral nutrition, maybe to reduce some components, dietary components, maybe gluten. We still don't know, but we need to find out for dietary triggers, and we need to look for ways to optimize and maybe to improve the response to this intervention regarding the induction of remission in patients with active Crohn's disease. Another study followed after patients with Crohn's disease and ulcerative colitis in Italy. This was not an induction study. Okay, they were treated by many kinds of medication, but they were recommended to follow Mediterranean diet for 6 weeks, and then they compared between this is baseline and this is after not 6 weeks, sorry, 6 months, and this is baseline and this is after 6 months, and you can see that both in Crohn's disease and ulcerative colitis that the after 6 months of following Mediterranean diet, they had higher rates of absent liver steatosis. They have improved CDAI or partial Mayo score, and a higher proportion of patients had a normalized level of CRP and fecal calprotectin. And again, this was unrandomized, and we didn't have any control group in this study, but this kind of highlights that it may apply and maybe research in other subpopulations as well, Crohn's disease and ulcerative colitis, and maybe in combination with medical therapy as well. Another aspect is improvement of quality of life. And in this study, this was the same Italian study, we see that from time 0 to after 6 months, we see a significant improvement in patients' quality of life according to the IBD questionnaire. Another reason, very interesting one, is the reduced overall mortality in patients with IBD. This was an American study. Actually, it was based on the nurses' health study and the health professional follow-up study. And what the researchers do is actually to follow after patients. They started with healthy participants, but over time, some of the patients actually developed IBD, and they have a long-term follow-up, and they can also record mortality as well. And they looked at 5 elements of lifestyle: moderate physical activity, adherence to a Mediterranean diet, light alcohol consumption, normal weight, and avoidance of smoking. And what you see here is the number of healthy lifestyle factors and mortality, actually the hazard ratio for mortality. And you can see that as long as you adopt as many healthy lifestyle habits, you had a reduced risk for mortality. The main causes for mortality in patients with IBD is not IBD. It's cardiovascular disease, cancer, and so on. So when you have IBD and when you treat patients with diet or dietary therapy, we should consider other chronic diseases as well. So here, the more lifestyle habit that you have, the lower risk for mortality, and specifically adherence to a Mediterranean diet was associated with odds ratio of 0.7, 30% reduction in mortality. So this is another reason why patients with IBD should be advised to follow a Mediterranean diet and lifestyle. And last but not least is prevention of IBD. Mediterranean diet is actually the only diet or dietary pattern that is associated with the prevention of IBD. This is a Swedish cohort, again, not within the Mediterranean region, but Northern Europe. So this is a combination of cohort of a Swedish man and Swedish mammography cohort. And what they actually, at the baseline, they collected food frequency questionnaires and evaluated adherence to the Mediterranean diet pattern. And here you can see the Mediterranean score, and the higher the score, the lower rates of development of Crohn's disease. So we see the inverse association with Crohn's disease, but we don't see the inverse association with ulcerative colitis, which is interesting. We do see the same trends with ultra-processed food for intake, for instance, that we see some dietary association with Crohn's disease development, but not necessarily with ulcerative colitis development. So this is interesting. And another study maybe can kind of complement these results. This is a very interesting study from the GEM project, the Genetic Environment and Microbiome project. They followed not patients or not healthy, but the first degree relatives of patients with Crohn's disease, which is interesting. We know that they have higher they are predisposed to develop a Crohn's disease. They have some genetic susceptibility, and over time, some of them develop IBD. And they followed after the microbiome, they assessed dietary patterns, they assessed lifestyle patterns, and so on. And they actually showed that patients that will develop eventually IBD, they have prior alteration in microbial composition and impaired barrier function. And in a very interesting study, they actually assessed their diet, and they found one dietary cluster, DC3, that actually resembled more the Mediterranean diet pattern. And in this dietary cluster, they found that it is associated with increased abundance of fiber-degrading bacteria and reduced low-grade inflammation measured by fecal calprotectin. So we have some biological rationale to think that the Mediterranean diet may also help in the prevention of IBD. At my PhD, I focused on the Mediterranean diet, and I try to focus on the biological effect, try to understand what happens to the patient, to the biology of the patient after following the Mediterranean diet. And we conducted observational studies at the beginning. We followed after patients with UC after pouch surgery, and we followed after patients with newly diagnosed Crohn's disease. And we collected longitudinally and prospectively food frequency questionnaires. And we assessed their adherence to the Mediterranean diet using this questionnaire. So the first observation was that adherence to a Mediterranean diet was actually associated with higher diet quality. Patients that ate more Mediterranean had a higher dietary fibers intake, more vitamin, more minerals in their diet, and it met more the dietary recommendation. We found an inverse association with inflammatory markers. Adherence to a Mediterranean diet was associated with lower CRP and significantly lower fecal calprotectin. When we analyzed the microbial composition, we found that adherence to a Mediterranean diet and components is associated with increased microbial diversity. In patients after pouch surgery, specifically fruit consumption was the main driver that actually it was more associated with microbial diversity, with the production of short-chain fatty acid, with butyrate producers and butyrate production. And it was inversely associated with microbial dysbiosis index. And finally, when we looked on disease course, we found that adherence to a Mediterranean diet and components was actually associated with lower development of pouchitis over time, lower rates of the development of pouchitis over time. This is in the case of fruit consumption, and over time with less hospitalization in patients with Crohn's disease as well. We then, all of these studies were limited to association and not toxicization, obviously. So we try to evaluate whether what will be actually the biological effect of the Mediterranean diet. And we hypothesized that, eventually one size does not fit all, and probably different patients will benefit from different strategies. So we actually try to compare a Mediterranean diet versus the specific carbohydrate diet, because we looked for a healthy diet that kind of differ in the composition as opposed to Mediterranean diet. A specific carbohydrate diet is more rich in animal-based products. Both diets are unprocessed. Both diets contain fruit and vegetables. And what we did is actually we collaborated with the chef. We cooked and provided the food and the meal to the patients' houses. Each diet was given to 1 week, with a 1 week of washout in between. And after a week, we collected a microbiome, inflammatory markers, blood tests, and etc., and dietary questionnaires, etc. And we were very surprised to see that actually both diets resulted in clinical improvement, but the biology of these two diets really differed. We see that the SCD was actually associated with increase in Enterobacter Klebsiella, while the Mediterranean diet with the reduction of specific taxa like Suturella and Cetobacterium. The metabolite composition was also differentially affected with these two diets. And it was very interesting to see that this was only happened after 1 week of intervention. So we can clearly see the clinical improvement, but the biology is actually differentially affected. We know that we won't be able to cook and deliver food to many patients with IBD, and we wanted to enlarge the scope of our studies. So we decided to develop a nutritional education program that is based on the Mediterranean diet. So it is called the IBDMED, the Inflammatory Bowel Disease Mediterranean Diet. And it is a microbiota targeted nutritional education program aiming to modify inflammation in patients with IBD. It is based on the Mediterranean diet principles, but it is microbiota targeted. When we targeting the microbiota, we don't want to cause weight loss or to normalize glucose levels. We want to target specifically the microbiome. So we actually focus on dietary fiber consumption. We want to increase dietary fibers. We want to diversify dietary fiber intake. Okay, it's not only the amount, but the diversity of the dietary fiber and the plant-based components in the diet. We included fermented foods in the diet. In Israel, it was very easy to use yogurt as a fermented food, but we recommend a consumption of different and a variety of fermented foods. And we try to reduce or minimize the consumption of ultra-processed food, which is, as I mentioned before, is also associated with microbial composition. We try to use a personalized approach, both basically more according to the patient preference and the patient phenotype, but we do try to also combine also some biological insights that will help us to direct the dietary recommendations to the patients based on the microbial composition and based on the metabolite composition. And we have, this is actually based on a nutritional counseling. We have an IBDMED application with a lot of recipes, information, chat with the dietitians. And as I mentioned before, Mediterranean diet is not only a diet, this is a lifestyle. So we provide step trackers and we monitor for number of daily steps, physical activity, stress, sleep habits, and so on. And we actually apply this approach in different study population. We have this approach in healthy control and in patients with early Crohn's disease, both in Israel and in India, and in patients after pouch surgery with active disease or inactive disease. And we hope that the different subpopulations will help us to understand can disease type, genetics, or geography mediate these diet microbiome interactions. I would like to show you some of the snapshot of the application. So this is the IBDMED application. We try that it will be very colorful and to make patients feel that this is healthy and this is fun, and they are not restricted with, the white rice and the chicken breast and very, very restricted amount of recipes and foods that they can eat. We really want it to be very popular and very trendy and very appealing to patients. So we have it is also adapted to the geography. Okay, so in Israel we have more Israeli recipes, in India we have more Indian recipes, but we try to integrate olive oil and other aspects as well, more fruits, for instance, more vegetables to the diet. So we have here recipes, we have chat with the dietitian, we have information, we have practicalities. Okay, it's very hard to eat Mediterranean diet if you have IBD. So how to do it, what about texture of the food, and so on. A lot of information that can be useful for the patient. And I want to show you some of the healthy pilot that we conducted in Israel. So we actually developed a daily score, that adherence score that ranged between 0 to 30. And in this score, we ask about only the positive components of the Mediterranean diet. Okay, how many fruits you ate, how many vegetables, olive oil, did you exercise today, and so on. We have 11 items. And you can see that within the 1 month intervention, 4 weeks intervention, we saw a significant increase in the adherence to the IBDMED. But over time, we see some declines. So obviously, we need to develop more maintenance strategies to maintain the adherence for the long term. But the majority of the participants in the study reported they actually preserved some of the habits for the long term. Regarding the components, you can see significant increase in vegetables, fruits, whole grains, olive oil, legumes, nuts, and yogurt intake. And actually, and interestingly, increasing adherence to the IBDMED intervention was associated with reduction in fecal calprotectin, in leukocytes, neutrophils, and lymphocytes. And we try to correlate between the dietary components and these markers. And you can see some clear clustering of the recommended food components that were actually inversely associated with these markers, while the less recommended or non-recommended food components of the Mediterranean diet were actually positively associated with these markers. So it was very interesting for us, and these were significantly reduced after 4 weeks of intervention. It's healthy participants, so it was within the normal ranges, but again, interesting. And next, we tried to assess the microbiome and what can explain microbial composition. So we saw again that leukocytes and neutrophils were actually associated. They actually co-clustered in two different microbial composition, which is interestingly relating to diet. So we saw again that the recommended food components were positively associated with specific bacteria, mainly fiber-degrading bacteria, while the non-recommended food components clustered were associated with other microbial groups, including Bacteroides. And very interestingly, we found that it's not only the diet, but also the lifestyle that is associated with microbial composition. As you can see here, the number of daily steps was positively correlated with Lachnospira and Fecalibacterium, two fiber-degrading bacteria that are considered to be beneficial especially for patients with IBD. So, if you want hypothetically to increase your Fecalibacterium, you should adopt a Mediterranean diet. Specifically, it is associated with food consumption, and you should walk more, okay? Increase the number of your daily steps. So all the lifestyle components are kind of integrated together and affect microbial composition. And finally, adherence to a Mediterranean diet was actually associated with increase of the absolute abundance, not the relative abundance, but the absolute abundance of many fiber-degrading bacteria that are considered to be beneficial. And I would like to show you some of the pictures. So the results that I showed you was from healthy participants. So these pictures actually derived from patients after pouch surgery. These are patients that have on a normal, they have normally around 8 bowel movements per day, maybe 1 or 2 at night. They have many bowel movements, and some of them are very concerned about, increasing their dietary fiber intake and eating more fibers. And I hope that you can appreciate the diversity and how the colorful, the plates and the pictures, these are pictures that the participants actually uploaded to the application, to the study application, and you can see how colorful, and you can appreciate the dietary fiber intake in their diet. They started to bake breads, and it's low processed. foods. And the picture that I like the most is actually this, because we really encourage them to do this diet with their family and friends. And this is one of the participants that actually took a picture of the plates of his children. So it's not only affecting them, it's affecting their family. And since, you know, Mediterranean diet might be associated with the prevention of IBD, so this is an additional effect, and this is a very recommended effect. Practically, this is hard. Okay, patients with IBD sometimes struggle with dietary fibers, and high fiber diet may not be appropriate to all patients. And this is the important role of the dietitians, as I see it. We can't, you know, just give patients handouts and, you know, let them struggle with it. And we need to guide them and to make adaptation according to the disease phenotypes, according to patient preferences, and so on. And I would like just a quick demonstration that we have, you know, different patients. So in the active phase, if you have patients with active disease and symptomatic, so you won't recommend on a, you know, raw salad. Okay, maybe it's preferred to eat it in a soup, cooked vegetables, to peel the vegetables, so it will be maybe to change a bit the texture, so it will be more tolerable. In the functional, we have patients that are in remission, but they have some functional component, so we can combine some of the principles of the low FODMAP diet, or maybe to choose low FODMAP vegetables. If patients have strict urine disease, so we can work on texture. This is the place that soups, smooth soups, smoothies, and so on can work better. And if the patient is non-active with non-strict urine disease, this is the phase that we can gradually increase the dietary fiber intake and to vary the vegetable. The same is with legumes. In the active symptomatic, maybe we can prefer tofu. In the functional component, it will be a bit challenging, but we can choose in moderate amounts of legumes that are considered to be low FODMAP. We are pretty limited here, but we can find some solutions, not necessary, but we can manage. If patients had a strict urine disease, so this is an example of some of hummus, okay, which is Israeli fast food, healthy fast food. So here, okay, the paste, you can use legume pastes, for instance. It will go more smoothly. It will be tolerated, more tolerated in these patients. And if the patient have non-active or non-strict urine disease, this is the place that we can diversify, increase, and gradually vary the dietary components. So MED in IBD take to clinic, start slowly with patients. Okay, they don't, you know, they can just eat vegetable salads with legumes and quinoa and nuts and everything that won't going to work. You need to do it gradually and slowly, and it depends on the patient phenotype. We should focus on increasing MED's recommended foods, okay? And sometimes patients feel very restrictive. We are actually in the era of exclusion diet currently, and some of them really looking forward to hear what they can eat in their diet. So by increasing the recommended foods, sometimes you can reduce the non-recommended foods. If we need to choose a target that we want to limit or minimize, so I would start with ultra-processed food intake. Try to work with your patient about the food labels, and, you know, educate them about emulsifiers and additives and sweeteners and so on, and their effect on the microbiome and inflammation. We need to tailor it to the patient according to disease phenotype, activity, needs, and preferences. Talk with them not only on what to eat, but how to eat. Cooking practicalities are very important in making the Mediterranean diet more tolerable to patients. Other lifestyle habits are also important, including physical activity, stress reduction, sleep. engage patients, family, and friends. It will make the process easier to all of them, and you might reduce the risk of other comorbidities to the patients or to his family. So that's a very welcome side effect. An important aspect, nutritional aspect, is monitor B12 levels, because when we reduce animal-based foods, we might reduce the intake of B12, especially in patients with active disease, or patients that after surgery, ileothectomy, or any kind of terminal ileum involvement. So these are the patients that are more prone to B12 deficiency and should be monitored. So to summarize, adherence to the Mediterranean diet is associated with multiple beneficial outcomes of patients with IBD, and I think it probably fits the majority of patients with IBD, and we can definitely, many of the patients can actually get benefits from adopting a Mediterranean lifestyle. It can alter the microbiota composition and function. And what I've shown is the Mediterranean diet that is more microbiota targeted. Okay, the IBDMED is actually associated with improved diet composition and reduction in inflammatory markers of healthy individuals, and in improvement of microbial composition. And it might be used as a microbiota targeted dietary intervention to modify disease outcomes in patients with IBD, but this remains to be proven in further studies. I would like to thank my team and my colleagues at the Rabin Medical Center in Israel, at the Gastroenterology Division and the Nutrition Unit, especially to Professor Iris Dotan, which is my mentor. And here you can see the team in action in a cooking workshop that we conducted to patients according to a Mediterranean lifestyle habits and principles. I would also like to thank our collaborators from the Gufna Lab and Shaishin Lab, and to Helmsley Charitable Trust that funds and supports our studies. And I would like to finish by telling you about the D-ECCO, the dietitians of ECCO. ECCO is the European Crohn's Colitis Organization. We have a committee of dietitians in which we try to promote diet and dietitians. We have annual conference with a specific dietitians workshop. We also have D-ECCO Travel Award that actually dietitians can go and to visit another center and to learn about practicalities and how they perform nutrition therapy in their patients. And we also have a D-ECCO research grant that I'm very proud of, that actually promotes dietitians and specifically dietitian-led dietary research, hoping and aiming to promote the field of dietary therapy and dietitians in IBD. And with that, I would like to thank you for listening.
Well, thank you, Dr. Godny. That was an excellent talk and really covered everything, in terms of the risk, prevention, treatment, and the impact of the Mediterranean diet at various levels. I'd like to take a few minutes to ask you some questions. One of the questions that's come up is that the impact of the Mediterranean diet in patients with Crohn's disease seems to be a little bit stronger than for those patients with ulcerative colitis. What are your thoughts on that? How do you respond? Is it just a matter of needing more research, or do you think that there's some difference in their baseline diets? How would you address that?
I think that it is actually true to the overall dietary therapies that we know, exclusive enteral nutrition, Crohn's disease exclusion diet, other exclusion diet are more established or more, proven to have any efficacy in patients with Crohn's disease as opposed to patients with ulcerative colitis. I think that it might relate to the mechanism of the diseases, and it's probably not like to Crohn's versus colitis, but probably to the location, maybe the small intestine versus the colon. We know that, maybe it is associated with the intestinal permeability, that maybe this is the effect of the diet, more related to the intestinal permeability, because we do see it in exclusive enteral nutrition. It works perfectly in patients with luminal Crohn's disease, ileal Crohn's disease, and less or not at all in patients with ulcerative colitis. I don't think the diets don't work in ulcerative colitis. I think that we don't have enough research for that. And the pattern that probably will work in ulcerative colitis probably differ from the patterns that will work in Crohn's disease. My hypothesis is that we need probably in ulcerative colitis to use diet to modulate more the microbiome. We know that, probiotics are slightly effective in ulcerative colitis, and fecal transplantation is also more effective in ulcerative colitis compared to Crohn's disease. So maybe it is more microbiota targeted. I still don't know, but obviously we need to wait, and I'm sure that in the upcoming years we will see more data relating to ulcerative colitis, both induction and maintenance.
Yes, that makes a lot of sense, and I agree, we do need more research. Clearly there's a lot of benefits for the Mediterranean diet, even outside of these early therapeutic effects that we're seeing. As you mentioned, it promotes improvements in cardiovascular disease, prevention in that way, same thing with neurologic disease and so forth. So more to come on that. For patients who are trying to actively incorporate a Mediterranean diet, it was really interesting to see your data on the use of the application. And I think a lot of providers don't necessarily have a dietitian in their practice. What would you recommend to either providers who don't have a dietitian who can guide patients this closely, or patients who are trying to sort of seek out options and don't necessarily have access to someone?
I think that, even if they go to a general dietitian and not specifically to GI dietitians or dietitians that specialized in IBD, so it can help, because it should be very tailored. It's not like gluten-free diet for celiac disease, which is easy, or even for low FODMAP diets, so you have today application or you have a handout and you can manage. Specifically in patients with IBD, they have a lot of challenges in applying this diet. But if you don't have, so I truly recommend to refer patients to dietitians. But if they don't have, so I think that again, start slowly, and you need to do the trial and error process and start with soft texture. Depends on the patient. Okay, you have like patients that can eat anything, almost anything, and they don't have restrictions at all. But if they have active disease or bowel narrowing or stricturing disease, so they need to be more cautious, and they need to peel and to use more like smoothies and soups and more soft texture, to use like grinding and do this cooking methodologies in order to make food more tolerable. But olive oil is easy to use in our diet. A fruit, so you can choose smoothies or like apple sauce or something like that to start that, and then you can gradually increase and try more and more food components and options.
That sounds great and makes a lot of sense. Obviously, we want this to be accessible for everybody and something they can integrate, based on their preferences, culture, religion, and so forth. In terms of prevention, one of the questions we get asked often is, from siblings, mothers, how can I prevent or lower the risk of IBD in my offspring or, in family members, what would you advise to them?
So I think that, relating to diet, so obviously, breastfeeding for pregnant women are obviously recommended. But if I think about like diet and lifestyle, so I do recommend patients and their families to adopt a healthy diet. So it's, according to the local recommendations. So again, in Israel, it's easy because the local recommendations are the Mediterranean diet. But I think that, to go with the local recommendations for healthy eating, I do discuss a lot about ultra-processed food, about food labeling, to look at the back of the package and to read the ingredients. And I talk with them about emulsifiers, what are emulsifiers, how to identify these food additives. And, this is the general recommendations that we want to reduce. I strongly recommend to adopt a healthy lifestyle and a healthy diet, and specifically the Mediterranean diet for patients and their families. So once, we meet the patients, we tell them, okay, so you start with that, but also, okay, engage your family. It will be easier for you, and they probably will benefit from it as well.
Yes, and definitely engaging patients with their families will probably also help promote adherence as well.
And it makes it more fun, it makes it more fun. Less, this is not a therapeutic diet currently that, this is only for you. I think that eventually you want to, go out and socialize and, be with your families and, during holidays and everything. So it makes it, I think, psychologically more easy for the long term.
Yeah, absolutely. And, it's important for patients to realize, it's not a religion, you can do your best, take it one day at a time, but even like you showed, 1 week or 1 month of changing your diet, moving towards a more Mediterranean style diet can make a difference, right? In quality of life, in inflammatory markers and so forth. So one of the questions we get asked often, especially as it relates to Mediterranean diet, is that there's just a much bigger emphasis on fish compared to other meats, such as chicken and red meats. And there are a lot of patients out there who say, well, but what if I'm going organic with my meats, grass-fed? Maybe it's more the quality of the meat, whether fish, chicken, red meat, rather than the animal source itself. What do you say to that?
Well, I completely agree. I think that eventually, so we know, regarding red meat, that, it kind of induces some signaling pathways and microbial composition that are associated with specific components in red meat, but it's also associated with processing. So from time to time, when you choose unprocessed, and that, like, as you mentioned, I don't know about organic, but because we don't really have good evidence for that, but grass-fed maybe. But the thing is less processed, okay? Try to eat it as it is on nature. So I think that this is, and I think it's what I like, in the Mediterranean diet, that we don't exclude anything, completely. Okay, from time to time you can enjoy a steak, so that's fine, So I think that eventually it's a matter of processing.
That was really a wonderful talk. Really
Thank you so much.
Comprehensive and just eye-opening. I mean, it's really amazing how far we've come in the past few years.
I agree. I started, at the time that, physicians told their patients that they can eat whatever they want and diet has nothing to do with their inflammation when I was was an intern. So currently this is completely different. And I think that patients, long ago recognized the importance of diet, but I think that dietitians and physicians, educate patients differently today.
Yes, absolutely. And it really drives home the point that, if we don't address diet, lifestyle, regardless, those are impacting patients, right? In terms of their symptoms, inflammation, quality of life. And so, it's in the best interest of patient care and outcomes really to, I think, address these in synchrony, regardless of, medical therapy, surgery, like you pointed out, even patients who have a new J pouch can benefit from dietary change and reduce the risk of pouchitis and so forth. So I think this was a very valuable presentation and very comprehensive.
Thank you so much. I enjoyed being here.
Well, I'd like to thank my guest, Dr. Godny, for joining me today. It was really great to have you on this webinar learning series for nutritional therapy for IBD. We thoroughly enjoyed your presentation on the Mediterranean diet for patients with IBD, and thank you for presenting your data. We look forward to seeing it in publication. I'd like to thank the audience members for your time and participation. And I'd also like to thank our sponsor, Abbott Nutrition, for making this webinar learning series possible. Have a great day, everyone.